So yeah, we want to record this historic moment. So I'm Rebecca Shirley. I'm a consultant colleague of James and Jeremy, who have recently joined our consultant team. And this is a presentation of a recent case which demonstrates well some of the complications of volar locking plates that we'll go on to discuss in the article. One of the things that James brought to us from Changgung Memorial Hospital is the presentation of each case done by one of the trainees before the case begins, and it just really helps to focus everybody, make sure everybody knows what's going on. And I use the basis of one of our registrar's presentations when I started to put this presentation together. So this is a case of tendon adhesions associated with a volar locking plate. A 31-year-old female, right-hand dominant teacher who had a chronic low body weight, and as a result of this, quite severe osteoporosis for which she's under the care of a rheumatologist, had been on multiple medications, had also had multiple previous fractures of a vertebrae, pubic rami and ankle in the past, and very fanatic exerciser. And on the 6th of October of last year, she fell off a bike onto her left non-dominant hand and sustained this injury. It's treated by our orthopaedic colleagues with this plate, unusually she went on to develop a compartment syndrome. So one day after the plate was fitted, she was taken for compartment fasciotomies, both on the volar and dorsum forearm. Then on the 13th, she went a relook and partial closure, and final operation had a split skin graft to the volar wound, and was left with a scar something like this. So her main problem was an inability to make a fist actively or passively, and she also had an extremely stiff wrist. Thumb flexion was extremely minimal, and she also had lost all extension of her index finger, and this was noticed to be a loss of tenodesis, so likely to be related to adhesion rather than muscle necrosis. So after much discussion, what we decided to do was to do surgery in 2 stages. I felt there was something that could be done to the extensor, but that it would be too much in terms of physio to address that. So we started by addressing the volar aspect with removal of the plate. So she basically had a distal defect which required soft tissue cover, and our goals were to improve her movement, provide soft tissue cover. And we also felt we could remove a hypertrophic scar that she had, and made a decision to do a free flap 2-team approach, and we went for an ALT. We did think about other options, and I think other options would have been feasible, but we felt we'll go for the workhorse. We're all familiar with it. In terms of positioning, we could go for the contralateral thigh and have 2 teams working simultaneously. Flap, of course, first described in 1984 by Song. This just gives a summary just of thought it was useful to put this slide up, just looking at, so first of all, like recipient vessel, we went for the radial artery. So you can see that distally, it's nice and superficial, and it does get deeper as you go more proximal. Other thing I thought was nice, just demonstrated in this, was the pronator quadratus, which we didn't find any evidence of when we went to take the plate out, and also just the position of the FPL and the FDPs, and you can see, sorry, just on this picture, how they are very closely in close proximity to the distal radius there. That's the ALT, harvested from the right contralateral thigh. This just goes through a succession of some of the surgical photos. I think what's useful in this photo is you can see just the resting position of the hand, and that does demonstrate some of the loss of function that she had. She really wasn't able to make much more of a fist than that, and you could see that the muscle, so the FDS, was adhered to the skin graft, but she also had loss of FPL and FDP, which we felt would be stuck to the plate, which is exactly what we found. So we also excised that section of hypertrophic scar while we were there. We thought we could be a bit more aggressive with silicone post-op, having done that. And then here's a series of photos. So you can kind of get a position, an impression here just of the, so this is just a bundle which is around, in fact, all of the flexors together. So FDP's FDS and the median nerve in there. And then on this side that's FCR and the FPL here. So the FPL and the FDSs here were very stuck down to the plate. And this photo here just shows with the plate once it's removed. So those muscles were all freed from the underside. This is a photograph just showing the plumbing. So it was an end to side on the radial artery. We actually had to go very proximally because the condition of the distal vessel was poor. But this is the recipient artery. And then we did end to side on cephalic and one more end to end on a vena comitan. That is a photograph of her post-operatively. She subsequently had a 5-day inpatient stay. We did advise her that she'd need to take a break from her marathon training, but she was spotted running less than 4 weeks after the surgery. Thankfully, didn't have any problems with her donor sites. And we started very early physiotherapy as an inpatient, and it was quite slow initially, but she is now able to make a good fist. And in fact, when I spoke to her just to ask her permission to use this case, she told me that she was moving better than when I last saw her before the coronavirus outbreak. So what we plan to do next when we get a chance is to do a tenolysis of the index. And I wonder whether one of the screws could have caused it to get stuck there. I think that's what must have happened. What's interesting is as her flexion has got better, she has experienced some radial subluxation of her extensor tendons of the index because they're stuck and there's just not enough excursion there for them to stay in their position. And at this point, we will also thin that flap. She's a very slim woman, and the flap at the moment is a bit bulky. But there you go, that is the case. So now I'm going to hand you over to Jeremy, who's going to talk about the paper.
Great, I'll just start my slide share now. So thanks very much for that, Rebecca, and thanks, James, and thanks everybody for coming and joining in. I hope you've maybe had a chance to download this paper. Sometimes PRS can be difficult to access. So we actually, James contacted PRS directly, and they gave us permission to make this this particular paper free to access for a period. So if you haven't downloaded it, you might want to download it as we're going on now. I think James has put the link up on the chat, so you can get it there.
Till the 25th, just so people know.
To the 25th, so you've got some time to download it and have a read. But what we thought is that this was a good opportunity to be able to look at some of the literature around complications from volar locking plates. So this is a paper, as I said, from this year, from the Mayo Clinic, from a unit that I've actually spent some time training in with Alex Shin, who's a senior author here. And it's the incidence of complications following volar locking plates with distal radius fractures, an analysis of 647 cases. So it looks like quite a big study. So the plan is to go through a summary, look at some of the key points from the paper, put the microscope or magnifying glass on some aspects of quality. So as we talked about in our journal club at Stoke Mandeville, we like to look at the quality of the reporting, in other words, how well written the paper is, and then actually the methodological quality, actually how well designed the study is. The two are often interrelated, they correlate quite strongly, and the second one is affected by the first one. If the paper's not written well, you usually can't always analyze how well conducted the study is, but we can have a look through and see. And then I've got a few discussion points that I thought were particularly salient and interesting from this, and then we'll open to the floor to discuss the case and other people's experience. And we're really grateful that we've got people from all sorts of places. We've got people logging in from all around the country here who I know have got a lot more experience with this kind of work than I have, and I'll be really grateful to hear their opinion after this. So, in summary, this is a single centre cohort study of volar locking plates for distal radius fractures. Most of those are the Zimmer Biomet DVR plate. Here's a picture of it at the minute on the left. They looked at their cases from 2000 to 2015, and they only included volar locking plate because the Mayo Clinic, I don't know if people have been, they do a lot of other fixation as well. They do fragment-specific fixation, and the guys there have actually designed quite a lot of the plates involved in fragment-specific fixation. But here they excluded all those, just looked at these kind of plates, which are probably have comparable to the kind of plates that are used by a lot of people here. There's obviously different branding, and maybe some of the guys who do more of this work will comment on that after. People were excluded if they had no x-rays either before or 6 weeks after the operation. So actually, if people had follow-up elsewhere, which a lot of people at Mayo Clinic would do, then they were also excluded from this study, and that's worth bearing in mind. They looked at major complications, which I've listed for you here. You can have a read through, and these they consider to be quite a big deal. Things like tendon ruptures, instability, arthritis, but also things like medical complications, radial artery injury, things that probably shouldn't happen. And then they also looked at minor complications, things that are less of a problem, some of which will resolve transient paresthesia, on the side of wrist pain, delayed union, and stiffness, and they lumped these things together largely. So what they included was 647 plates out of about 910, and that, bear in mind, is 647 plates and 636 patients out of 910 in their database. So that's 70%, 69.8% follow-up. So that's often, that seems quite good, though really the standard you'd really aim for is 80%. So the fact that it's below 80% does raise a bit of a question as to whether there's some bias. It's nearly a third of their cohorts are missing. They had a mean follow-up of 9.1 months, and that's worth bearing in mind because if people went on to things like plate removal, it was typically at around 400 days later. So some of these patients, it sounds like that mean follow-up was shorter than some of the kind of complications might happen. And then they looked at what the outcomes were. Now, it's worth bearing in mind that these numbers sound large, 647, but actually if you divide 647 by 15 years and by the number of hand and wrist surgeons that are at the Mayo Clinic, which I looked at their website last week and there were 12, that works out at 3.5 procedures per surgeon per year. So although this is quite a large cohort, it's not necessarily a huge amount of operating, assuming that they've had that many people for that many years and that people have been doing similar numbers of cases. So that again is worth bearing in mind. But they reported 13.8% of the cases having major complications and 17.5% having minor complications, which their abstract said is a low complication rate, but I think it's not insignificant numbers of problems here. They went on to use regression analysis to try and see which kinds of factors and variables were associated with having problems. And in multivariable analysis, which controls for some of the confounding, they found that high BMI, over 35, increased your risk of major and minor complications. Being old, defined as being over 65, increased the risk of major problems. And having an intra-articular step after the operation was associated with having major complications. What I would say here is they put in quite a lot of covariates. So if you break it all down, because they even put different plate types, all sorts of things, they ended up with 25 different covariates in their modeling. Now, if we bear in mind that of the 647 procedures, 89 had major complications, that it means it's actually quite hard to know whether they really have got enough power for this analysis. So bear in mind that what drives the power in a regression analysis is not the total number of people necessarily. It's actually more to do with how many people there are who are different, because what you're looking for is what's different. So what was different about somebody with a major complication compared to people without. So if you had 647 procedures in it and only one had a major complication, it's pretty hard to run much analysis because you've only got one person who's the odd one out to draw all your comparisons to. The fact that there is hundreds in the other group is quite limited because it's that one person that tells you what's different. So here they only had 89 people who are different. Normally you say you need 10 events per covariate. So that will be about 8 or 9 things you'd be able to study, and they've studied 25. And that does make a difference because the statistics that drive and underpin that modeling start to disintegrate if you try and put too many covariates in. That's probably another discussion for another day. But it does raise some questions here. So, on that note, what do we think when we get our magnifying glass out? Well, for how well written this paper is, I would use the Strobe Checklist. So this is standardized reporting of observational studies in epidemiology. It's basically a checklist for how well written a paper that is not a trial or a systematic review is. There's 22 criteria in that, and most of them were met, though they didn't really explicitly describe their study design early on. That's not too much of a problem because it's pretty easy to figure that out. How their sample size was justified and what power they had for their analysis is not discussed, and we've just seen on the last slide how that might have been a problem. The details of the analysis, so the regression is really skimmed over and they just cite the major results. And what they certainly don't do is they don't give you the unadjusted estimates. So when we went here, this is BMI adjusting for age, intra-articular step, all sorts of other things. What I'd normally expect to see is the BMI in its raw form and then the adjusted form. That tells you about how much confounding there was. I think this is where it gets a little bit difficult in a clinical journal because a lot of clinicians probably don't want to see all that stuff. But I think it probably needs to be in an appendix because that really tells you about how clean and well conducted their analysis was, and it's not there for you to see. There's just the end results. So that's how well reported it is, and it's pretty good. In terms of how good the actual study quality was, well, there's a couple of ways you could approach this. So this is different. So the first bit we looked at was the paper well written. This is actually was the study well designed and done. So there's the NIH checklist. They have checklists for different study designs. So you could use that. And there's also QUIPS, which is basically the quality of prognostic studies. It's a tool for studies that use multivariable models like this, regression type models. I've combined both of them into a summary and basically said where they fell short here was, again, they didn't really tell us about the sample size in enough detail. They didn't explain why that 30% of people were missing. So as I said before, there were several reasons why people might have been excluded, but they didn't tell us which reasons accounted for the exclusion here. So it's a bit hard to know whether there's bias there. As we said, the time frame might not be adequate. 9.1 months of follow-up is not that much on average, particularly when you're removing plates 400 days later, over a year later. And there's some issue about how you define prognostic factors. You know, if you're going to put smoker yes, no into your model, well, what is a smoker? Is a smoker somebody who smoked before they had their injury? Is it somebody who smoked during it? Did they smoke 1 cigarette a week, 20 a day? Did they stop smoking afterwards? Did they stop smoking for a period, then restart smoking? What is that? To simply say smoker yes or no is quite a difficult thing to model. So even through these checklists, there'll be some points that would raise some concerns. I think there's a few other things I'd like to talk about here. And what I think really is interesting in a cohort that's run over a long period, this started in 2000 to 2015, all the operations that were done in that period. What I'd like to talk about is how this whole study was designed and the school of statistical thought you have. So what's interesting here is we always tend to default to what we call enumerative statistics, which is this statistics of trials. You do one thing over and over and over. So the blue circles might be KYs, you might KY over and over and over. And the orange triangles might be Volar locking plates. You can do Volar locking plate over and over and over. And the assumption being that the first one you do is just the same as the last one you do, and then you take the average in the group because nothing has changed in that group. So you're already an experienced surgeon at the beginning and you're an experienced surgeon at the end, and you can take the average of a group and compare it to a different group then to see which did better. And that's how trials work, and that's why we're taught about these kinds of statistics, even if you don't know they're called enumerative statistics. But it's the idea that it's a fixed thing that you're just reproducing and then taking the average of. In contrast, if you go to a factory like the Toyota factory near Nottingham or Derby, they're interested in how processes work and how things evolve. And industry develops something called analytic statistics, which is this idea that it's a conveyor belt that's constantly changing and updating. So that the first one, your first go at an operation is probably not as good as your 2000th go at an operation. And taking the average of those does not necessarily make sense. But what you might be looking for is shifts or trends. And I would put it to you that even if you feel like you're more comfortable with the first set of statistics, this kind of idea of take the average of one group and compare it to the average of the other group, we all actually understand what an analytic study is. Because if you look at somebody's OBS chart and their temperature has been running at 37, 37, 37, 37, 37, 37 all the way, and then it jumps to 39, you don't take the average of that and say, well, the average is 37.1, I'm going to do nothing. You say the temperature was running at 37 and it's now flipped to 39, something has happened. This conveyor belt has changed. There's been literally a shift that's defined in analytic studies or a trend, and we need to do something about it. And I think this is really relevant for this study because they've taken an enumerative approach, but I put it to you that this is probably more an analytic situation because in 2000, how many people were doing volar locking plates? Now, I'm not an orthopedic surgeon, so, or I forgot to say, so the beginning of your study, this is Justin back in his youth now, straight out of the hairdressers, you know, on his first volar locking plate. And Justin as an old man, a wise old head who's now done thousands down the line. And you might well expect that by that stage, things have improved for him in terms of his outcome. They might have deteriorated, of course, towards the end, past his peak. But this idea that things can change over time.
Have you just done that to make sure you know I'm listening?
Yeah. Made sure. I thought Justin would enjoy that. Public humiliation. So going back to the point, so how many people were doing volar locking plates back around 2000? Well, here's data from a Kevin Chung paper looking at what was going on back in the late 90s and early 2000s. And if you look at the kind of the green line, it was a few % of distal radius fractures were receiving internal fixation of any kind of volar locking plate in 2000. It's risen steadily, and the data from Matt Costa's preparatory work before he did draft was that in 2010, 44% of surgeons in the UK preferred volar locking plates. Now, it's not quite exactly the same data, but it just shows to you that things have really risen and taken off. So the point is, when this study or when this cohort began, people were probably not doing very many plates. I don't know how many they were doing at the Mayo Clinic, maybe not many at all. So some of these guys will have done their very first plates in this cohort, and they'll have also maybe done many, many more later, so that by 2015 they had a lot more experience and were doing them very differently. So why does that matter? Well, it matters in terms of how you approach the analysis, because we know that there's a learning curve with doing volar locking plates. It relates to surgeon experience, and being early in your career is a really strong risk factor for having complications. And the problem, if you take an average like they did here across the 15 years and say the complication rate was blah %, is, well, were those all front loaded in 2000, 2001, 2002 when everybody was learning what to do? Or have they been evenly spread through the 15 years, which is what this implies? Or isn't that today, actually, if you have your volar locking plate done there today, the complication rate's way, way lower because people have now done lots of these plates and they've got better. So that actually saying, well, the complication rate's 13.5% for major complications is not true. It's actually a lot lower. This is difficult to tell unless you actually describe what's happened over time, and they haven't done that here, which I think is actually a limitation that I think undermines this study of quite a large number of cases otherwise. So are these average complication rates meaningful? Can you use it? If you quote this to your patients as well and say there's a 13.5% major complication rate, well, is there? Or is it a lot higher if this is your first plate? Or is it a lot lower if this is your 200th plate? Are all surgeons equal? I mean, the Mayo Clinic, is a center with a high quality reputation in the United States and high standards. Is that the same in the place down the road? But are these results representative to any surgeon now, given that you've averaged over such a long period? incorporating probably learning curve and perhaps new surgeons joining the team. The other thing I wanted to talk about is the analysis. So as I said, without going into too much detail about regression, one of the beauties of it is that you can control for confounding. So does body mass index affect outcome when you control for diabetes? So this is relevant because perhaps having high body mass index is associated with having diabetes, and having diabetes might lead to complications. So that if you just look at the body mass index, part of that effect is not body mass index itself, it's the fact that high BMI people also have diabetes, and the diabetes is causing part of the problem. Regression lets you strip that out and say, okay, so if we control for diabetes or fixing for diabetes, does BMI alone in its purest form affect complications? So that's a nice thing to do. We talked about how the powering of this study might be problematic, but there's another issue here with how they've run this. Let my cuckoo clock finish, and that will tell me that I need to move along quicker as well. So we look at high BMI, and we see that it's associated perhaps with medical complications, but it might also put you off reoperating on somebody because high BMI patients have high risk. We as surgeons know that. So there can be an increase in some kind of complications, but a decrease perhaps in others. And the problem in this study is they label both of those as major complications. So what we might have here is another issue with the analysis, which is if you've got some complications going up because of a factor and other complications going down because of a factor, but you've clustered them all into one entity called major complications, that's obviously going to muddy the water of your analysis. So I'm not sure how reliable those findings are or how you would interpret them. Because as it may be, the high BMI, the high age, and the intra-articular step might be associated with some things, but not with others. And that's quite complicated to pick apart when you've clustered them all together. So what I have here, just to wrap up, is a summary. So the blue is effectively what the paper is quoted as saying, and the red is what I would challenge you to consider here. So they've said that, this is a large single center cohort study that shows that there's a low complication rate, and they've used regression analysis, which is good. And they've found that being older, having a high BMI or an intra-articular step may matter in terms of being associated with complications. But I put it to you that the complication rate, which they've labeled as low, however you choose to feel about that, low or high, I'm not sure whether it's meaningful. And I suspect that the complication rate today at the Mayo Clinic is lower than what they've quoted in this paper, because I think they've averaged across their whole learning curve. I think some of those complications are notable, and I'm not really sure that saying that 13.5% major complications is low. I would be a little bit nervous about taking their regression analysis at face value, because I think it's underpowered, and I think that does affect the statistics. As I said, they've combined a whole bunch of things into this heterogeneous endpoint of major complications and another one of minor complications, which does make it quite hard to analyze. And then to compound that, you do have some tricky covariates, as we said, like smoking. What is smoking? What is a non-smoker? What is a smoker? And how do you actually put somebody in a box in terms of their behavior like that for an analysis? So that's what I would like to say. And I think at this point, there's one last thing I want to say, which is often in our journal club, I get slated for tearing apart papers and taking them to pieces. And people say, well, do you base your practice on anything? And I think what I would say to that is, I think what's important to me is to be able to analyze the paper for what it is. And there can be good papers that are really well designed, but that won't change your practice because the ultimate message doesn't matter at the end. And there can be effectively relatively poor papers with lots of problems, but which might still influence your practice because the message still makes sense. I wouldn't step into the road in front of a lorry. I haven't read any trials or high quality studies that tell me not to do that, but I'm quite happy to follow that practice in the absence of high quality studies, or even if there was a very poor study, I'd still be quite happy to accept it. So I would say I've identified some problems here. I'd be interested to hear what other people have to say, but I wouldn't rubbish this or rule out what they're saying from this paper entirely, but I would just say these are some of the issues that you need to carry forward and incorporate into your decision making. Thanks very much.
Thanks very much, Jeremy. So has anyone got any questions or comments? If you do, then please click on the raise your hand thing at the bottom of your Zoom, or I can see you, Max, and I'll unmute you. Great, go ahead. Can you introduce yourself and tell us? Yeah, sorry. And tell us.
So I'm Max. I'm an orthopedic surgeon, and I've been working as a consultant fixing wrists for about 10 years now. Thank you both of you for your presentations. I thought they were really, really good. Jeremy, I mean, I picked up pretty similar points to you in a lot of those things. Two things which I thought might have been relevant is the way they defined their complications was quite interesting. And I think that could or should be debated, because I think CRPS is quite a big complication, and I don't know what a medical complication is. And I also think some of the inclusion criteria, I think, I'm not sure if they were comparing apples with apples all of the time. You know, fractures that needed supplementary K-wires and had what they called styloid fractures or head fractures, I think probably skewed things a little bit. And then another thing is they didn't have any outcome measures, which they acknowledged as a deficit in the paper. But I think it would have made a big difference to know whether their complications really were significant, because lots of people have their metal work out and they just describe it as a little niggle. And again, they don't really describe, they call it metalwork irritation, but they don't describe, you know, your case that you presented really is probably a metalwork complication and adhesions. So I think I don't know, I think outcomes would have been very useful in that paper. Just a question regarding your case that you did. Other than, I mean, you flashed through the x-rays quite quickly. I mean, what do you think caused those dorsal adhesions? Because that's quite a thing.
Yeah, well, it's interesting. And the truth is, I think until we actually go in there, we won't completely know. But I considered maybe ischemia of the muscle, but I think that's really unlikely. And on the table with the tenodesis test, it really felt like it was stuck. Now, it seems very unlikely that it would stick to metalwork.
Yeah.
The only thing I can really think is that a proud screw has got caught. And I think perhaps if her flexor tendons weren't moving well, that may have predisposed more of a problem.
And at the exploration for the compartment syndrome, I mean, was there a definite cause? Was there a bleeding vessel or a tight? Did they do it through a tiny little incision? What was their proposed reason?
Reasonably long incisions, and I wasn't there, but the surgeon that was said that there were multiple hemorrhagic infarcts on the muscle. And there was minimal muscle necrosis, because I had wondered, like, this is a slightly unusual woman, whether maybe it wasn't a true compartment syndrome. But from the clinical, they didn't measure the pressures, but from the findings, it certainly seemed that it was a proper compartment syndrome.
Okay, weird.
Yeah, and I think I agree with your points, Max, about outcome measures being useful, and you know, it's really interesting to talk about things like removal of metalwork, and particularly to talk about that in a different healthcare system. You know, having spent a little bit of time there at Mayo Clinic, it's really interesting. A lot of patients fly in for treatment from quite long distances across America, go back. I'm not quite sure whether they've captured removal of metalwork by all comers at all places. You know, if you fly in there, have your plate done, and a year later have your plate taken out back on the West Coast by somebody else, I don't know whether that's captured. I don't know how that's remunerated. I don't know what kind of other factors have influenced practice there. So it's really interesting. And then, like I say, and as you point out, once you then cluster that all into some heterogeneous mix of complications, it becomes a little bit difficult to pick it apart.
Yeah. Also, sorry, I've spoken too much, but the last thing I'll say, they throw in a conclusion on the last page, which is limitations of volar locking plates are shown by the study. And I'm not sure if I agree with that conclusion. I'm only an orthopod, but if the limitation is that you have complications associated with diabetics and high BMI, that's a limitation. But for me, a limitation would be you can't use it for certain fractures, you can't use it. I'm not sure about that conclusion.
Yeah, I think it'd be interesting to hear what other people in the audience have to say and what they think about this. I suppose my view would also be that it's difficult to also say that without some kind of comparison to how other treatment modalities fare, because unless you can say, well, yes, putting whatever K-wires in, or perhaps some of the TriMed fragment-specific plates that Alex Shin's designed and declared his financial conflict of interest for, unless you can show that they fare better, it is what it is. I don't know. We've got a really great audience here. I don't know if other people have thoughts on that, comments to add.
Evening.
Uh-huh.
Hi, I'm Pickard. I'm an orthopedic surgeon. I'm Max. I've been using Volar plates for 20 years and was the PI on Drift. And I'm really intrigued to see how many other people here are busy grafting their distal radius fractures, because in 22 years, I have never grafted an acute fracture. Or corrective osteotomies, I don't graft either. And they're busy grafting, what, nearly 30%.
That's a good
pickup. Who else grafts?
Nope.
Because they observe that increases the complication rate, and I'm sure it increases the remuneration rate.
Yeah. Unless they've got these massive smashed up polytraumas, which I don't think they have. Another interesting thing in the study is they talk about a what do they call it? They called it a unimodal distribution, and then they said it's young men and older women. That's not unimodal. So the only thing I could think, Simon, is they have hundreds of really smash wrists, but no, very bizarre. I don't bone graft things ever.
I mean, I'm not a great scientist. I thought it was an interesting recollection of the last 15 years of the Mayo. I didn't really view it as a great scientific paper. So I don't think it's going to change my practice. I'm intrigued by aspects of it. But I think the conversation's got a long way to go, and I'm not sure that added a lot to the conversation. Rebecca, as an orthopedic, on behalf of all the orthopedic surgeons here, why did you revise the skin graft?
So the thing was that the FDS tendons were adhered to that, so it was affecting their gliding. So by putting a flap, we had a fascial layer, which meant the FDS tendons could glide well as well. I mean, that
it wasn't just because you could.
It's very standard plastic surgical practice to put a flap on. And James had just come back from Taiwan. He was desperate for cases, and I thought, perfect. And I definitely think it was the right thing to do. And I think she's going to have a better functional and cosmetic result as well.
But I think, would it be fair to say, though, that the first line treatment for the acute fasciotomy closure would still be the same? I don't think. Would we advocate doing anything different at the closure of fasciotomy?
I mean, I have grafted a few of those and been in those situations, usually more with the bigger traumas, but I've found that waiting with a VAC for a reasonable period of time, and I'm not scared to put a VAC over a metalwork in those situations, not needed a graft, but I have no qualm putting the graft on, but probably like Simon, and this is where it gets a bit tribal and it's quite fun, and of course you had a brilliant result, so we can take the piss out of you. I might have serially excised, and I mean, Jeremy's worked with me before. I might have, jiggled and wiggled and played and what I call moving a bit of skin around. I know you can't really advance things there, but you got a great result.
I think it depends very much on how old the fracture is and whether the metal is really on show. I mean, if you try and extrapolate from the lower limb literature, the flow investigators looked at, did an RCT that was published in NEJM a few years ago, looking at the outcomes of negative pressure therapy on open lower limb fractures. And they found that following a letter to the editor that the bone infection unit from Oxford wrote to them, they had to do a further post hoc analysis and found that the longer the FAC was on, the odds ratio for getting a deep infection was much higher. So for someone who was young and had metal work on the show, and there wasn't much muscle, soft tissues overlying it,
yeah,
metal work with mostly tendons, I have to say, when I saw initially, I thought a flap would have been the right thing to do to prevent all these problems. And I think it's slightly an attitude problem as well. I think if you went to a place like Taiwan, where I did my microsurgery fellowship, doing a free flap is so routine that it doesn't, it's not a big deal at all. And I think in many units here in this country, it's become such a big deal that it becomes an obstacle for us to try and do what I consider sometimes to be the right thing. And it's isn't it? It's to do the right thing the first time.
You're absolutely right. No, I think you're to be commended. You got a great result. I think she's a tricky patient, and I think you have to be decisive with tricky patients, because if you give them an inch either way, you're going to be in trouble. So,
just as an observation, for if you're going to decompress a forearm, if you take your skin incision more ulnar, right over to almost to the ulnar shaft, then your flap, when you can't close it, has FCU exposed rather than median nerve and the flexed tendons. And just something to think about. I would take your incision far more ulnar. I know you guys didn't do it, but it solves the issue of having bare tendon and nerve.
See that Carlos Palu has asked a question on the chat.
Oh, right. Okay.
If he's being shy, or maybe he's lost his voice because he was talking and chairing yesterday's really great Pulvertaft talk by Jay McEakin. He said, do obese people get worse distal radius fractures?
He's not here anymore. Oh, yes, he is. Sorry, Carlos, I'll unmute you. Okay. Can you hear us, Carlos?
Yes. I think there is a high risk of complications for obese people. Is it because they get worse fractures?
Well, what was interesting here is one of the reasons why they ended up with so many covariates in that model, 25, is because they put the entire AO classification in. So if you're talking about worse fractures as in a higher AO grade, it's a clumsy plastic surgery talk for something, but then here they've adjusted for that, and the higher BMI people seem to have higher complication rate, adjusting for AO-based grading of the fracture. Now, I don't know if you would accept AO-based grading as a way of meaningfully classify how bad your fracture is or not.
That's a reasonable thing, because if a fracture it's a higher energy fracture, you'll have more comminution. It will be more difficult. So people who are fatter, they fall, they'll put more energy on the wrist. But it is interesting that's not the whole story. They get more complications for other reasons, but it would be interesting to know exactly why.
Yeah, well, that is interesting. So I think here what they've managed to show, though, is in this particular set, if you believe that analysis, and we don't quite know how stable that analysis is because they haven't given us all the detail, it looks that on top of probably some confounding, high BMI matters by itself. If they'd given us the raw and the adjusted values, we've been able to see how much that would have shifted, and maybe seen how much having a high BMI plus getting a bad fracture from your high BMI matters, because you would have seen the change from the raw to the adjusted odds ratio, which was not presented for us here. So that was a shame.
Thanks, Jeremy. I also wanted to make another comment, because I was around in 2000 fixing distal radial fractures, and I had the first 2 DVR sets in Europe exactly that plate. And the thing that changed a lot were the indications. Like I got to Derby as a young consultant, and I said, I think we should fix distal radial fractures. And they nearly kicked me out of the consultant meeting, saying, well, you can put it in a plaster, put a couple of KYs, there's nothing wrong with that. So the only ones I was allowed to fix were the very, very bad ones. And if you look at my results from the early years, the complication rate is high. It's not so much the technique, it's the indication that changed. Then down the line became much more acceptable. And by 2010, we were fixing everything, which is when Max started. I probably was going around telling people to fix everything, and that's what we did. And then as we had more evidence, we fixed less. So the whole fashion has changed, but the results have changed mainly because of the change in indication rather than the change in technique, I think.
Great. Matt's been waiting a while. Matt, did you have something to say? Matt?
Yes, yeah, sorry, I was just starting the video. I was just following up the discussion from Max around the management of the skin graft and indications for the flap. I was just going to be slightly antagonistic and probably sit on the more kind of orthopedic side of the argument. I was just wondering whether a couple of local anesthetic serial excisions would have, tissue expanded the skin, closed it, so you had a scar that was more aesthetically pleasing than an ALT, which you're now going to come back and thin, so there's further operations.
Yeah, so I think the fact was, because we also felt there were adhesions to the underlying plate and we were going to take that out as well, it made sense to combine it with a flap. And I think because we need to go back into the extensor aspect, thinning the flap is something we'll be doing at the same time as an extensor tenolysis.
Okay.
That was the thinking. If it was just a case of addressing that defect, then yeah, I would have had a go at serial excisions. I think because the main problem was really with very restricted finger flexion. So we wanted to go in, take the plate out, do a proper tenolysis, and then in that situation, it seemed much better to get really robust soft tissue cover.
Just a follow-up, I wonder whether anyone's had any experience with sort of acellular dermal matrices or other synthetic sheets in this sort of case to prevent recurrence of adhesions or to provide a further layer between skin and underlying tendons?
Not me.
No, I haven't really got any experience.
So no, but I've had minimal experience of ACM in breast surgery, and a few cases I've seen, they've all had infections. I'll be very worried about infections near metalwork and fresh fracture.
Sure. Okay, great.
That's anecdotal.
Thanks. Nice presentations, by the way. That's very good. I'm gonna go now. Bye.
Simon, sorry, you've been waiting a while. Maybe Simon's gone. Okay. Max.
There you go. Can everyone turn on the video for a moment and just comparing to the Mayo paper, show with fingers what percentage you would quote in your consent form for complications overall? Just out of interest, let's just all show what you would reasonably say to a patient as you think, what is the percentage chance you would give for a complication?
Any complication?
Yeah, combination of these. So he's going on any toes? Any toes in there? Okay. All right. Okay, you turn off your videos. So, yeah, I mean, maybe 7.5, somewhere in between the two. I mean, yeah, 17%. I'm not sure if I'd let a surgeon operate on me on a 17% complication rate. It's quite high. Realistic, but quite high. Do we think it's high?
Yeah, I must say I don't like to give a percentage for any complication. It just seems fairly made up.
Yeah.
It's been interesting in some of the papers I've been looking at in preparation for my PhD next year, looking at rates of infection in some of the bigger trials in hand and wrist trauma. And they even just infection, which is one complication, they do seem to be a bit higher than what we generally think of clinical practice when you're actively looking for them in a trial. I can't exactly remember the number, but I think for draft, the rates of infection for volar plates were around 10%. And certainly in Kevin Chung's paper as well, the rates were higher than that, between 10 and 20% for infection.
Yeah. Okay.
Anyone? No one's put their hand up. Can I ask Jeremy just to comment on the analysis of the paper? You pointed out that defining what the smoker means is a problem. Putting all the different complications into one box is a problem. Can you educate us on how you would approach that analysis and how it would be more useful for clinicians?
So like I say, I think if you want to combine things into that, I think there's a couple of things to think about. First of all, are they things that are going to have some kind of monotonic relationship, i.e. go kind of up together? You don't want things, one thing goes up, another thing goes down, all lumped into one endpoint, because that means that somebody who's kind of at zero is kind of, could be yes to one thing and no to another thing. You get that kind of problem. I think you have to ask yourself what actually really matters, and I think that you could prioritize that better. I suspect this is maybe a symptom again of having a database. They've got a very good database in the Mayo Clinic. I've been there, I've seen what they've got. Everything is inputted, and I think this is whatever is inputted gets extracted and analyzed. I think like Max has said, you quote complication rates to patients, but you probably quote certain things. You probably don't quote an overall complication rate, which would be very synthesized and heterogeneous, and you probably don't necessarily quote some very minor things and maybe tell them, probably, I'd expect to be told something like reoperation likelihood, perhaps, specifically, rather than major complications. So I think what this kind of lacked in terms of that endpoint was actually a clinical and even a patient-focused perspective on what really matters. Which of those complications does a patient want to know about? Which is going to affect their life meaningfully? And then I would have probably analysed that. And like I said, I think walloping in loads of covariates model is quite problematic, and that's sort of a discussion for another day. But it basically, stats disintegrate if you've got you don't have enough events, enough different people, enough complication people for the number of covariates. And I think putting in all the different plate types and all the different fracture patterns by all the AO subgrades is probably excessive unless you've got some sensible reason to do it. The other thing you can do is actually run your model in a way that actually strips out stuff that doesn't make a difference. So you can run what are called stepwise models, where you basically only add things in if they influence the outcome. So that you get what's called a parsimonious set of predictors. Then you haven't just bunged everything in, you've only added stuff in that makes a difference.
Right. Has anyone else got any questions? We should wrap up soon. One final comment, anyone?
I'll give you a final comment, and it's that the bit that I'm concerned is people diagnosing this CRPS on patients, and what happens is that people have so much pain they cannot use their hand, and everything else that comes with it is disuse: the swelling, the change in color, the traffic changes, the changes in the X-ray. And our job is to find out why they've got pain and sort it out. And all these patients are sortable. And they fall into groups. They have nociceptive pain or neurogenic pain. And both groups, if you can find the cause, you'll sort them out. Yeah. So it breaks my heart to see a list of complications CRPS. CRPS means they have not looked for the cause of the pain. They have not tried to sort it out. They've elected to dump the patient onto the physios or the pain clinic. So I would encourage people not to do that. Find out why the patient has got the pain and sort it out.
Great. Thank you. Okay, so I think we should wrap up here. It's 9:30. I think